Thank you, organizers, for giving me this opportunity. I'll be speaking on the management of diabetic macular edema. So basically, management of diabetic retinopathy deals with management of diabetic macular edema and dealing with complications of PDR. So this talk is about DME. To tackle DME, we have laser photocoagulation, which we used to do many years back, but now it's getting reduced and reduced because of the availability of injections. If it so if we are talking of injections, then now we have so many possibilities available that we are spoiled for choice. And then there is also a role of surgery for vitreomacular traction cases. And last but not the least, metabolic control has to be emphasized in order to manage these cases. So what drug to choose? Each drug has its own pros and cons, and what regime to follow. This is basically the topic of this talk. Should loading doses be given, and is PRN right from the word go? What is the end point of injections? To be honest, there is no end point. Patients keep on getting these injections. And what about non-responders? There will always be non-responders, whatever drug you may choose. And then there are complications of intravitreal injections. So this talk is about early intervention, which leads on to lasting benefits. And in these trials which I mentioned, Vivid and Vista, they shown that visual gains were observed as early as the first injection of aflibercept. Why we are talking only of aflibercept or Eylea? Because it's become standard of care now. All the studies, new molecules are coming, they are dealing with non-inferiority as compared to aflibercept. And patients, they received greater than 8 injections through year 1. They maintained these vision gains. And across all these studies, patients treated with aflibercept, they gained an average of greater than 10 lines. And all the international guidelines, recommendations, now they support the use of early intensive treatment. So that's what you have to emphasize to your patients. To get the treatment as early as you detect them with DME, you have to spend time with them, you have to consult them, you have to show them the results of the various studies so that they can agree with these early interventions. And also you see these studies also show that 87 to 93% of the mean letters gained at 1 year had been gained after 5 monthly doses of aflibercept. So the early, what we call is a loading dosing thing, is very necessary. Mainly in private practice, what happens is when a patient comes to you, you detect him with diabetic macular edema, you just talk to him and tell, okay, you need an injection, but you never emphasize upon the possibility of many injections because you don't want to lose a patient. Once you're talking about 5 injections to the patient, the cost involved in the patient, you are afraid that he'll run away. So why should I lose opportunity even about 1 injection? But this is needed if you really want to retain the patient for long. And this also study, this graph shows that delaying aflibercept treatment led to poor vision outcomes because here you see that these, in the lower line, the light gray line, it shows that the patients who had received laser, once they were eligible to receiving intravitreal injections, they did not gain the vision, which the upper two lines show, which the patients who were given early injections. And this graph shows you that the intensive anti-VEGF treatment in year 1 may facilitate a reduced injection burden thereafter. So this is what we need to explain to the patient, that if they are getting injections every month or so initially, later on in year 2 and 3, their need for injection goes down. So ensuring adequate continued follow-up and treatment as required after the initial loading dose can maintain vision gains seen early in the treatment through even to year 5. See here, the vision gains with aflibercept were sustained through year 2 with a reduced treatment burden in protocol T of DRCR-NET. And this slide shows that the randomized controlled trial experience can be obtained even in the real world experience with early intensive treatment. These patients who received, the Moorfield study shows that these patients who received approximately 7 injections in year 1, they had gained about 11.2 ETDRS lines. And the other graph shows that patients who had not received this, the gain was very poor. So in summary, we can say that early intensive treatment with greater than 7 injections or 7 injections in the first year can deliver clinically meaningful visual gains equivalent to randomized controlled trials. And the take-home message should be that based on these studies, we need to change our thinking of management of diabetic macular edema. We need to counsel the patients for early intensive treatment. And how to do that? It is that you can give them complimentary OPT visits, you can give them complimentary OCTs, and what I have started doing in order to promote this better molecule is I am giving bilateral injection the same day, because the drug is enough to be divided it into 2 eyes, and in the same cost I am not increasing the cost. So I am reducing my profit margin in order to give a better molecule to the patient. You can also do telecounseling to the patients who are not following up, and I think we should all pool our data and our own real world experience publication.